Welcome back. Let's apply what we have learned to some case studies. In case one, we have a young woman during an exam, a high stress situation, who has what appears to be a seizure. Let's walk through it. When EMS arrives, she's not postictal, not in that typical confused state after a seizure. Instead, she's conscious, crying, and saying, "Help me," even as her arms and legs are jerking. Speaking or crying during what looks like a generalized seizure is a big clue. Generally, in a true epileptic generalized seizure, patients are unconscious and not purposefully vocalizing. The crew notices her eyes are clenched shut the whole time. Interestingly, research indicates that if a seizing patient's eyes remain forcefully closed, it strongly suggests a psychogenic seizure. One study quoted a 94% chance it's PNES if eyes stay closed. Conversely, epileptic seizures often have eyes open or rolled back. The episode lasted around 10 minutes, which is quite long for a typical tonic-clonic seizure. Those usually last 1 to 2 minutes. Psychogenic seizures often go longer. They can go on 5, 10, even 15 minutes or more, whereas most epileptic fits are brief. The patient also had no postictal confusion. She was immediately alert and oriented when the shaking stopped, which is unusual for a generalized epileptic seizure that usually leaves someone confused or drowsy for several minutes up to hours. We have her history of anxiety as another piece of the puzzle, and the context, stress of an exam. All signs pointed toward this being a psychogenic non-epileptic seizure, a type of conversion disorder. However, and this is key, the EMS crew did not have 100% certainty in the field. They recognized the atypical signs, talking during seizure, eyes closed, long duration, immediate recovery, that suggested a psychogenic event. But as professionals, they know we cannot definitively diagnose that on scene. So they smartly followed a cautious approach. Ensure it isn't something dangerous. They protected her airway and head during the seizure activity and checked vital signs. Everything was stable. Often in PNES, vitals are relatively normal. In a true seizure, you might see tachycardia or postictal elevated BP, but anyway. They also checked blood glucose to rule out a hypoglycemic seizure. It was normal. No signs of trauma or other causes. They did not immediately administer IV benzodiazepines as one might for status epilepticus, because they noted she was not in a typical status. She was interacting. However, some EMS protocols might still allow a benzodiazepine for an active seizure-like episode beyond 5 minutes. In this case, they primarily used verbal coaching and reassurance. They spoke to her calmly. "You're okay. We're here with you. Just try to take slow breaths." They also subtly tested a bit. In some cases, responders might try a gentle trick like raising the arm and letting it drop, the old hand drop test, to see if they avoid hitting their face, though this is not very reliable and can antagonize the patient. The crew here focused on de-escalation. They did not restrain her. That can worsen a psychogenic seizure or cause emotional trauma. Once the episode resolved, they found she was fully alert, another confirmation of PNES. They then proceeded with normal care, an ECG perhaps, though she's young, likely fine, but maybe to be thorough, and transport. They documented everything objectively. Found patient with generalized shaking, eyes closed, responsive to voice. Episode lasted approximately 10 minutes, ended with patient alert and crying. They avoided labeling it as fake seizure anywhere in the record. They just described it, more on documentation soon. At the ED, with no neurological cause found, she was diagnosed with a conversion disorder event. The follow-up for such a patient is typically neurology and mental health referral, like therapy to handle stress. The key takeaway for EMS from this case: treat seizure-like events supportively and safely, even if you suspect they are psychogenic. You won't harm her by providing care as if it were a real seizure, maybe giving a benzodiazepine, which actually helps anxiety anyway. But you could harm trust by openly doubting her. They struck the right balance, prepared to treat for a true seizure, but recognized the features of PNES, and mostly provided emotional support and safe transport. In case 2, we have what initially sounds like a classic cardiac emergency: a middle-aged man with chest pain and palpitations. He himself is convinced he's having a heart attack. However, our crew happens to know, or quickly learns, this is his third similar scare in recent times, with prior evaluations finding nothing. That sets the stage that this might be an anxiety or panic-induced somatic symptom rather than a myocardial infarction. But of course, we must be careful. On arrival, the patient is extremely anxious, even saying, "I know I'm dying." He's hyperventilating, breathing very fast, which is causing that tingling in his hands and around his mouth. We call it carpopital spasm when your hands tingle and sometimes cramp from low CO2 due to overbreathing. His vital signs are telling, yes, heart rate is a bit high at 110, likely from panic. But blood pressure is okay, oxygen is 99%, and he's not cyanotic or sweating heavily. The ECG is essentially normal sinus tachycardia, So, objective signs don't point to a heart attack. He has no history of cardiac issues, but he does have known anxiety disorder. This history is crucial. If you learn this from him or family, it increases suspicion that this is a panic attack masquerading as a cardiac event. The EMS team still follows protocol. They check him out thoroughly to rule out the serious condition first. They likely gave him an aspirin early on, since chest pain protocol often calls for it and it's low risk, although in the scenario he already self administered one. They did not give nitroglycerin because his pain description might not have been typical angina, and his blood pressure was fine. Plus, giving nitro to an anxious, hyperventilating patient could actually drop pressure and cause more panic. Instead, they focused on calming measures. They spoke to him in a reassuring tone. Sir, we're here and we're checking you out. The monitor looks okay at the moment. That's a good sign. Let's try to take some slow, deep breaths together. By coaching his breathing, they helped him blow off less carbon dioxide, slowing the hyperventilation, which in turn started relieving the tingling and some of the chest tightness. Often, chest pain and panic comes from chest wall muscle tension and overbreathing. Essentially, they used a bit of therapeutic communication and breathing retraining. As he calmed slightly, they updated him. Your blood pressure and oxygen are good. This is reassuring. We don't see signs of a heart attack on the ECG right now, but we'll take you to the hospital to be sure and so you can feel safe. This kind of explanation helps because you're acknowledging his fear, we'll make sure, while also injecting reality and reassurance. Vitals and ECG are okay. They transported him, of course. Even if 99% sure it's a panic attack, one wouldn't leave such a patient at home because, on the off chance there is a cardiac issue, you don't want to miss it. In the ED, not surprisingly, all tests were normal. The ED likely labeled it a panic attack or anxiety related chest pain. A note: people with this illness, anxiety, or panic driven pattern often feel embarrassed afterwards. It's good that the EMS team handled it with empathy. In fact, you might recall hearing patients apologize. I'm sorry, I thought it was real. We should be supportive and reinforce that it's always okay to call. Chest pain is scary and we're glad it's not serious. Anxiety can absolutely cause those symptoms. That sort of debrief helps the patient feel less ashamed. From a system perspective, repeated calls like this can strain resources, so such patients ideally need connection to primary care or mental health resources. Sometimes EMS or the ED will flag the case to community paramedicine or psych services if available. But in the moment, our job is clear. Treat what we see, in this case mainly anxiety causing physical symptoms, and don't ever ridicule the patient for false alarms. Each case we approach fresh, because one day it could be a real heart attack. This case highlights how illness anxiety or panic can overlap with EMS high acuity complaints, and how we can manage it with both medical assessment and calming techniques hand in hand. To wrap up, let's reinforce the most important points from this lecture. The mind and body are connected. We've seen how stress or psychological issues can manifest as physical symptoms, sometimes mimicking life threatening conditions. As EMTs and medics, recognizing this doesn't mean we treat it less seriously. It means we have a broader understanding of what might be going on. Always remember, just because labs are normal doesn't mean the patient isn't truly experiencing something. It might be their mind manifesting distress through the body. Respect that. Treat patients with dignity and compassion. People with somatoform or conversion disorders have often been through the ringer. They may feel nobody believes them. We should not add to that trauma. Even if internally you're thinking, this is probably anxiety, externally your demeanor should be caring and attentive. These are our patients, not annoyances. If you show irritation or call them names like frequent flyer within earshot, you'll damage the trust and potentially worsen their anxiety. And guess what? That could even trigger more symptoms or more calls. A thorough assessment is non-negotiable. Do not let a previous psych, label, or your hunch cause you to skip steps. Somatoform patients can have real emergencies too. They can have asthma and panic attacks. They can have appendicitis and chronic abdominal somatic pain. So do your full assessment each time. That said, once you've reasonably ruled out immediate threats and things aren't adding up, it's prudent to consider a somatoform explanation rather than ordering unnecessary aggressive interventions in the field. It's a balance. But bottom line, if unsure, transport and let the hospital sort it out with more advanced diagnostics. It's better to over triage than under triage. Communication is a treatment tool. We emphasized how using the right words and tone can actually mitigate the patient's symptoms. Conversely, saying the wrong thing can escalate the situation or deeply hurt the patient. So always use professional, calming, and validating language. Avoid words like it's all in your head. Rather say, I know you feel this pain. We're going to take care of you. Documentation and handoff. We went over how to do this factually and respectfully. Remember that your documentation is part of how we as a system treat the patient. It should reflect empathy as well, certainly no derogatory remarks. A good handoff to ED includes your concerns and observations so they continue where you left off. Know our role. We're not psychiatrists, and we're not expected to cure somatoform disorders on scene. Our role is stabilization, support, and facilitating further care. But we should also recognize that what we do and say in those critical moments can have a lasting impact. Some patients later recall, the paramedic really listened to me and made me feel better even though nothing was physically wrong. That was the first step in me getting proper help. We can truly make a difference beyond just the physical realm. In conclusion, somatoform and conversion disorders are part of the spectrum of emergencies we face. They require a nuanced approach, medical knowledge, psychological insight, and human compassion. By understanding these conditions, you'll avoid pitfalls like missing a true illness or mistreating a patient, and you'll provide care that is both safe and empathetic. Thank you for your attention. Remember, treat the patient as a whole, mind and body, not just the symptoms. In EMS, we often say treat the patient, not the monitor. In these cases, treat the patient, not just the disease you suspect. If you do that, you'll always be on the right track.